welcome everybody to our quarterly combined multidisciplinary APSA SVS Pediatric Vascular Surgery Interest Group webinar. And for many of you that are on the call, you've joined us before, and we've really circled a lot of different themes and diagnoses across kind of our pediatric patients that have vascular challenges. Tonight, we've identified developmental vascular disease as our topic theme. We're going to spend the first half of the webinar concentrating on pediatric vascular anomalies, and Dr. Shahan and Tamita will be moderating this session. So I will let them introduce their invited guests, and myself and hopefully Dr. Morrissey, if he's able to get out of the operating room, will be moderating the second part of our time together. And we have a panel of several experts who will kind of go through and discuss a few different cases. And I hope this can be kind of a constructive and interactive format for everybody. So for all of you that are sharing your evening with us and that care about these kids, I just want to say thank you for prioritizing the webinar and sharing your time with us. I'll be short and sweet and just share a little bit of, I guess, housekeeping before we dig into the meat of the webinar. And that really is that Mary is recording this for us. And so we hope to archive this so that it will be available to SVS and APSA members for future reference. Super duper important that as we're talking about patient scenarios in particular, that we're mindful and respectful of patient privacy and identifying kind of information. So please keep that in mind as you're discussing cases and or raising your own questions during the conversations and the discussions later. So I'm going to stop sharing my screen. I'll pause and just make sure there aren't any questions or needs from the group as we start our hour off together. Awesome. I'm going to turn this over to Dr. Shahan and Dr. Tomita, and thank you for launching off this webinar. It's going to be great.
Hey, great. Hi, everyone. I'm Sandy Tomita. I'm a pediatric surgeon at NYU and a member of the APSA SVS task force. I'm going to give a short presentation on multidisciplinary approach for vascular anomalies, and then Dr. Francine Bly, who is my colleague at NYU, and will give a presentation with some cases and clinical pearls for surgeons. So let me start my presentation. Birthmarks have been long described in medical books, but until recently, has really not been a part of traditional medical training. The first formalized collaboration to study vascular anomalies was established in 1976 by John Mulliken in Boston and Anthony Young from London. These two surgeons went on to found ISVA, the International Society for the Study of Vascular Anomalies, and whose current president is actually Dr. Bly, who is our next speaker tonight. The first ISVA classification was published in 1996, and in the 1990s, some children's hospitals established formal vascular anomalies programs, and most notably at Boston Children's Hospital. In the 2000s, as our knowledge expanded to include the medical management, the understanding of coagulopathies and genetics often involved in these lesions, the role of the pediatric hematologist, oncologist in these anomalies became central to the success of these programs. Just to illustrate how our knowledge of vascular anomalies, how far they have come, our knowledge, one can look at the many changes in the classifications of vascular anomalies over the years. From 1982, when Mulliken and Julie Golacki from Boston created the first system, to 1996, when ISVA's first classification was created, and then updated in 2014 and 2018. This is the most current classification from ISVA in 2018 and reflects many of the advances in clinical, radiologic, histopathologic, and molecular knowledge that has been gained since we first started studying these lesions. It divides the lesions into tumors and malformations, and it's available from the ISVA website, and it's really nice. It's interactive, it's downloadable, and clicking on these different categories takes you directly to more information. So if you look at the first category in infantile, that contains infantile hemangiomas, you can also go to the details, which shows you the different patterns and types and its association with other lesions such as face. The other tumors include borderline tumors and malignant vascular tumors. The vascular malformations are classified by vessel type, so capillary, lymphatic, venous malformations, arteriovenous malformations, and combined vascular malformations. ISVA also has anomalies of major named vessels, and there's a list of syndromes that are associated with vascular malformations, and a list of unclassified anomalies, including P10 and FAVA. In addition to an appendix which has abbreviations, there's a list of causal genes of vascular anomalies, a list of coagulation disorders that's associated with many of these anomalies, and a list of PIK3CA related overgrowth related anomalies. Another example of the advancement in the treatment of vascular anomalies can be seen in the dramatic decrease for surgery of infantile hemangiomas. And this table illustrates the dramatic decrease over a period of 8 years with the use of propranolol in infantile hemangiomas. The other advances in the treatment of vascular anomalies include genetic testing, next generation sequencing, the identification of mutation-induced signaling and vascular anomalies, which led to targeted therapies such as sirolimus and the PK3CA inhibitor, the prenatal detection and management of these anomalies, the creation of international databases and patient advocacy groups. So multidisciplinary care has long been a model for many complex diseases such as oncology care and burn care, and is especially suited for vascular anomalies, as many of these conditions are uncommon and they can affect a wide range of areas. The two traditional models for multidisciplinary care include the virtual model, in which the visits are separate. There's usually one provider who does a comprehensive and detailed history and physical, followed by a multidisciplinary discussion. And the concurrent model, which involves a separate clinic away from each practitioner's clinics. There is the patients see all the providers in one space. It's definitely less efficient for providers, but can be one stop for patients. There's a potential for some disjointed evaluations, and but a lot of programs make this model work. And one thing to think about is the reimbursement for multiple providers may be difficult. So if one is to establish a vascular anomalies program, these are the team members that should be considered, with probably the more important ones towards the left of the screen. At NYU, we started our program 2 years ago, and it's led by Dr. Bly, a pediatric hematologist oncologist, and Dr. Gaffey, a pediatric otolaryngologist. Here are the other team members involved. And I would say that the relationship between the providers is super important, as well as a really good support team who can write detailed treatment plans discussed in the conference and do the necessary follow-up and coordinate appointments and care between team providers. Since we started our program, we now have up to 80 referrals per month. We meet virtually every 3 weeks, and there's a lot of individual contact between providers. I just wanted to show you our template that we use for our conferences, which gives a summary of the patient's history, and as well as photographs, labs, data, imaging. In conclusion, I like to say that the multidisciplinary approach to vascular anomalies really renders collective knowledge among multiple specialists. There's a potential for increased referrals and revenue for your hospital and practice. Some of the challenges include the logistics of finding a time for multiple clinicians to meet, as well as the management of adult patients and children who transition to adulthood. It does require constant support and buy-in from your institution, and the collaboration and relationships within and outside your institution are really important. And one way to start is through an ISFA membership. So that's all I have, and I think we'll move on to Dr. Francine Bly.
Thank you, Sandy. Can you hear me?
Yes.
Yeah, okay. That was great. Okay, so we will go to my presentation. Hold on. Okay, can you see that?
Yep.
Okay, and then let me just go to slideshow. Here, view, slideshow, and there we go. Okay, so thank you very much for this introduction. So Sandy did a really wonderful job in summarizing the field. I have been in the field of vascular anomalies as long as I can remember, actually. It's something, even during sub-internship many, many moons ago, I had a patient who had vascular anomaly that kind of gave me the itch for this. And I think you are either interested in these patients or they're not. They can be very, very complicated, and there's a great variety in diagnoses and severity. Some are really very simple and easy, and some are extremely complicated, even to those of us who see complicated patients. So we'll start. So I'm going to start with, and also what I tried to do is not focus on HEMONC, but focus on the big field and obviously the surgery aspect of it. So this is a patient, it was a baby who was called for a surgical consultation because there was a sternal defect. And it was actually not diagnosed prenatally. So does anyone have any idea of what else you should be looking at on this patient besides just what you're going to operate on? Okay, you don't have to tell me, but okay. So when you look at the whole patient, he actually had this pink area here, which you're not sure if this is a port Weinstein or hemangioma, but it's segmental. And if you just even wait a few more days, it's going to turn out to be a hemangioma. And when you see that segmental hemangioma and a sternal defect, the first thing that comes to your mind after you see enough of these patients is something called face syndrome. So you need to have minimally, with rare exception, a segmental hemangioma, usually in the face or neck or head and neck area, although there's also some exceptions to that. Once you see that, it's really state of the art obligation to work these babies up for other issues. One of the less common complications could be a sternal or midline deformity, but you should always feel for it. There could be a supraumbilical raphe. These are things that surgeons can certainly be called about. The segmental distribution, the hemangioma, and the beard distribution rings bells that there might be a symptomatic airway hemangioma as well. There can be brain structural abnormalities, which often are diagnosed prenatally, but the arterial anomalies really can be extremely complicated. They can be absence of vessels, corkscrew vessels, tortuous vessels, and over time they can lead to issues. So and there could also be cardiac anomalies as well as eye anomalies. So, oops, sorry. These patients require that type of multidisciplinary approach. There are guidelines. I have a list of articles that I couldn't put in a slide, but this consensus derived paper is good for face. It probably needs to be revised, but that's what we need to think about with those patients. And then a corollary, well, and that idea of the segmental distribution versus focal hemangiomas that seem more random led to a lot of research about are these random or not. And it seemed that the focal hemangiomas are often along these lines of mesenchymal ectodermal fusion. Okay. The other segmental hemangioma type that I think surgeons could certainly be called to consult on are these severely ulcerated hemangiomas in the perianal area. They're usually midline. That you can see this pallor here. These are like flesh-eating ulcerations. They can be really painful, difficult. When you see that, there's the obligation to work these children up is to rule out something called lumbar syndrome, which is lower body hemangioma There could be urogenital defects. They tend to ulcerate, but the U is for those two. They must be worked up for potential spinal abnormalities. There could be bone deformities, which are less common, anorectal malformations, which you may become involved with, and arterial anomalies or renal anomalies, and also urogenital. So these are also in a segmental distribution. Okay, and it's not as common as the other, but it's something to think about. Okay, I'm not going to go into the detail that Sandy did, but this does give us the guideline. So it's for classification. It is under revision. Those of you who might be ISFA members, you're going to get an email shortly for some feedback about the proposed revision, which was many years in the making, and it's never perfect, but it is a helpful guideline for management. I'm going to skip over now to vascular malformations, which you might be more, become more involved with. And these are very heterogeneous and they're very visual, and you kind of have to know also what to look for. This was a gentleman who came to me with nosebleeds and bleeding in his mouth, and he had many children. He's from an Orthodox community. He had many children who had similar problems, and that's the family history is always important. And this patient ended up having hereditary hemorrhagic telangiectasia, and there needed to be a whole workup for those patients. I think the case that will be presented after our talk is Clove syndrome. Here's a patient that has Clove syndrome with, hypertrophy of fat. Surgeons become involved with these patients because we like to get a biopsy of the tissue for genetic testing. It's a somatic mutation. Sometimes there is debulking surgery, less so now because of effective medication. This is the patient who came with a swollen cheek. It was soft. There were no associated issues at the time, but on the clinical reportal here is that this transilluminates. And when you see that, you can even see the septations. This is a lymphatic malformation. Very simple test, no cost, just use an otoscope in a room and make it dark. What else? This is a patient who was born with kind of a checkerboard blue vascular lesion, and this ended up being a glomovenous malformation. That's not really surgical, but this is a patient also with Cloves. It's a different patient. It may be the same one. They have leg length discrepancy. There can be sandal gap that is very common in these patients. There could be lymphatic malformations. These are patients that you might see, for infection care, wound care. What else? This is also a lymphatic malformation. This patient had something called Proteus syndrome. It's like very, very thick skin on usually the feet with dysmorphic digits and cystic lesions in the lungs. And now there is a treatment for that as well. So basically, they may walk into your clinic, certain things may be more relevant to the surgeon or not, but honestly, no one physician can take care of these patients. It really, truly is multidisciplinary, and you really need to have, surgeons and dermatologists and radiologists. This is a patient who came with dilated vessels and a capillary malformation here. And it wasn't like classical for Sturge-Weber syndrome, but he ended up having seizures and an abnormal MR. So, it's not always you look at the book and they look at the picture. Something I'll just go over quickly, but it actually could be relevant to your practices, is that there have been real strides over the past 15, 20 years in genetic studies in patients with vascular malformations. And there's two major categories. And one is when there's a germline mutation that generally comes from one or both parents. Many of the germline mutation disorders and vascular lesions are autosomal dominant. And interestingly, the parent may not have they may not express the gene fully. So the patient I showed you with the glomovenous malformation, her father had the gene, but he didn't have any obvious manifestations of the disorder. When I examined him, he just had one little dilated vein and then the popliteal fossa. And she had very extensive disease in the same gene. Knowing that was important because they wanted to have other children, and they were able to do prenatal pre-implantation genetic testing and IVF and prevent having another patient with that. When it's a somatic mutation, it is not a gene that is passed on generation to generation. So that's a genetic mutation that happens in utero, and seemingly depending on when the mutation occurs, the disorder can manifest itself in just one area or many areas and be more serious. And it's a mosaic mutation. So it's only diagnosed by studying affected tissue, and the degree of expression of the abnormal gene can be very low, and not all laboratories will report that as potentially significant. So we send the samples only to specific genes. Sometimes you can have a combination of both. It's unusual, but it's occurring. And sometimes there are postnatal, like second hit mutations. So it is getting more complicated than just this, because some patients don't have the clean one or the other. Some clinical pearls that just kind of knowing that. So, and that's why a family history is important, because you may see, the child, and there might be other children that need to be worked up, or parents that need to be worked up. And this is P10, there could be a P10 mutation associated with macrocephaly and different types of vascular malformations, but they're also prone to malignancies. So that would be important to be monitoring those. But these are the most common familial genomic mutations. And many of the, I'm sorry about that. Many of the patients that we see have these kinds of syndromes, which are somatic. Cloves is one of the more common. That's congenital lipomatous overgrowth, vascular malformations, epidermal nevus, spinal anomalies, scoliosis, and many of these are this PIK-C3A mutation, and sirolimus is medication that targets that, and as does alpelisib. Proteus syndrome I had spoken about. FAVA is something you might see because their patients come in with a painful mass, often in the lower extremity. Sometimes they are amenable to surgical resection, and other times they're treated with medication. Blue-Rober-Bleb is something surgeons see because they're small venous malformations that are all over, including the GI tract, and there could be very significant bleeding that can come to the attention of surgeons. I'm not going to go into detail, and I'm sure the next talk will have some discussion of this, but what's occurred is it seems that initially we were only thinking of this pathway, but it turns out, and these are what I've discussed thus far, and these are the drugs that are targeting those disorders, but many of the arterial malformations are actually on this side. And there are different drugs, and some of them are quite toxic, but they seem to be effective. And there's also some lymphatic malformations that have some crossover. And there's different medications that are being used, but I won't go through all of those details. So, and we knew nothing of this 20 years ago. So it's really quite amazing that the field, first of all, no one used to be interested in this. Now it's like really hot. Now all these pharmaceutical companies are actually interested. Another area that surgeons may become involved with or are involved with are fetal diagnosis. There might be a role for fetal surgery for some of these patients. Sometimes there's areas that need to be drained. I saw a patient recently who was prenatally diagnosed with a big lymphatic malformation that was drained elsewhere prenatally, and then postnatally we did some sclerotherapy. This is wrong. And also fetal medical therapy is now coming into fashion. It's actually been used routinely in tuberous sclerosis, but now it's being used for significant lymphatic malformations where you actually treat the mother with sirolimus, and we're trying to kickstart that in different institutions. This is very busy, but it gives you the whole story. It's from a British group. It's the St. George classification of lymphatic malformations. I find these things extremely helpful when you have a new patient that is not very straightforward. You just look at one of these, which genes to start to look for, which I'm very visual, and these patients are very visual many times. And then, this is very, very helpful. And then lymphedema is something surgeons now are being, or historically have been involved with. One of the doctors that's been very involved with this is in Sweden or Finland, I'm sorry, Dr. Brorson, and he had published a lot of work about liposuction for treatment of lymphedema. There are some centers that are using that as a treatment, and sometimes it's a surgeon, sometimes, a pediatric surgeon, an adult surgeon, vascular surgeon, or a plastic surgeon, depending on the institution. And then there was a relatively recent paper by the Boston group and also the Swedish collaborators, so Dr. Borson, where they combined debulking surgery and liposuction, and they found that they demonstrated that it was more cost effective than conservative therapy, which is basically massage and compression. So that is something that surgeons would be interested in. And then the other surgery that's being done for lymphedema are vascularized lymph node transfers, or lymphaticovenous anastomoses. And there's many papers that have been published about this. And the techniques are really being perfected every year. So I don't know the latest and the greatest, but if you're the type of surgeon that's interested in this kind of work, there's lots of patients that would like to benefit from that. They're starting to treat more children with this. The issue is, though, that they still need to do the massage therapy and the compression. So I don't know what the best treatment is, but this can be very effective. And lymphedema is not a pleasant thing to have to live with. I'm going to end with some resources, and you'll have the slides. So again, it's just really helpful to be able to learn from what others have put together, aside from just papers. So the Europeans are very well funded for this European Reference Network for Rare Diseases. And these are the diseases, these working groups, and they meet very frequently online and also in person. And they really have workshops to really knock out guidelines, and they're publicly available. There's patient pathways. Again, they just show the arrows to what to do, what to look for capillary lymphatic venous and malformations and severe hemangiomas. And most of those have been published. They're starting a do's and don'ts page. Right now, they just have the hemangioma page. One thing, and that's really important to know, because there are certain areas you don't want to biopsy a certain lesion, and certain things you must work up. So, and then they also have consensus statements. So it's not just one or two people. It's really very multidisciplinary and international within the European community. And that, I think it's really great. So and they're, most of them are ISFA members. So I'm just going to go through this. It's hard to read, but you'll have the slides to look at it because it's being recorded. And they just show you, if you suspect something, what to do, what to look for, what it could be, genetically what it might be. And then there's the clinical evaluation, the investigation, the treatment, and any associated genes. And, it's just so much work that goes into this. And then, even further with more diagnoses. When you do this long enough, you kind of have this in your head, but it keeps on getting revised. Okay, and then management and treatment, what to look out for. And then some of the, especially venous malformations, but other diagnoses might have a coagulopathy, and that's where you bring the hematologist in. There's certain blood tests that need to be done. One thing I don't have a slide for, but this is reminding me that for patients that have venous malformations, the females should not be taking estrogen containing birth control. And not only for birth control, sometimes adolescents are put on birth control pills for acne or irregular periods. And these are very prothrombotic, and these patients can develop phleboliths, clots, pain. In general, they may have very abnormal veins with very sluggish flow. And there's more and more interest in women who, now that they're getting older, having infants, becoming pregnant, and also freezing, egg freezing, freezing ova, to prolong, to have an infant in the future one way or another. Pregnancy is possible. It is high risk. They need to be followed by maternal fetal medicine. We put them on anticoagulants, and there's a workup we do ahead of time. But it's something that if you have a center and it includes children, adults, or you need some hand over to an adult service, they really need to be aware of this. Okay, the other resource is patient support groups, and some of these patient support groups are extremely helpful. In fact, most of them are, because they are very motivated. They know their diseases. They have patients that are looking for help. They have funding. They work with some of the pharmaceutical companies, and they have really contributed to a lot of the success in the field, and also political pressure on Washington. The lymphatic, I'm sorry, it's gonna be terrible for the saving it, but this lymphatic educational network worked with Washington, and now there's better insurance coverage for lymphatic therapies and support hose, and now there's more NIH funding for lymphatic research. And some of these organizations actually have funding and grant opportunities. So they're very worth connecting with. What you might not be familiar with is the Journal of Vascular Anomalies, which is the ISFA journal. It's only online right now. It's not on PubMed, but it's achieving all the guide posts that it needs to go through to become indexed in PubMed. And once it is, then every article will be retroactively placed in PubMed. They're really interesting articles, and there's reviews, there's how I do things. It's all online, and you can also ask for issue alerts, and then you get emails with the new articles that are being published. Sandy mentioned the meeting we have. It's really a great meeting. Already over 500 people have registered. It's going to be in Madrid. It's very, very multidisciplinary, and we're really trying to encourage younger practitioners to be involved. We want, from all different disciplines. We need a lot more adult practitioners as well. And there's some new initiatives that we will roll out. So we look forward to new members. And you would just go to that website to join. And I thank you for your attention and welcome any questions.
That was fantastic.
Thank you.
Such a great talk. I really enjoyed that. Should we do the questions at the end? I'll do a case presentation and have Dr. LeBlanc do a commentary, and then maybe at the end we can direct any questions based on our remaining time. I'm going to share my screen. So I am Dr. Claudia Shea, and I am a vascular surgeon at LSU. I've been involved with our anomalies program at Children's Hospital for the past 15 years approximately. And so this has always been a big passion. I think this case will do very well for illustrating why a team approach really is essential, or at least very helpful in these kind of cases. And I did obtain parental consent prior to presenting this case. So our case today, it's a 4-month-old female with a history of a malformation since birth involving her left chest and retroperitoneum. It was very large. You can see here on exam a large soft mass. She has a secondary mass at the upper back posterior neck area that is more firm and movable and different in consistency. So we ordered an MRI and a CT scan. This MRI illustrates very nicely the relative size of the mass and the large draining veins. And the CAT scan demonstrates very large macrocystic lesion and microcystic lesion, no arterial component. You can see a lot of venous component to this. So, we would classify this as a low flow lymphovenous malformation. You can see the enormous size of the lesion for this 4-month-old baby. And, looking at this lesion, you can see that it's approximately almost the size of her entire body. duplicate. And you could see a multi-septated lesion here with these very, very large draining veins, which would, this would be a large resection and quite an undertaking with some morbidity. So based on this, our anomalies clinic as a team, we decided to try to wait until she was about 1 to 2 years of age, where she may tolerate the extent of the resection a bit better. Now, she did present 2 months later with fever 102. You can see the erythema over that lesion there. She was treated with broad spectrum antibiotics, and she did respond very well to that. Because of the high fever, we did do an ultrasound guided aspiration to see if there were this was pus or abscess, but as usual, these cultures usually come back negative. She did respond to IV antibiotics. 2 months later, she presented to us in our clinic. She'd had some enlargement and bleeding in the malformation. You can see here the appearance of the lesion does appear to be bruised and discolored and very consistent with bleeding. And you can see both lesions appear to be growing a bit faster than we were comfortable with, or at least faster than we were hoping. And you could see here on ultrasound is what we had obtained at this point. You could see the hyperechoic areas in those large macrocysts consistent with the bleeding into those large cysts. And you can see here as we extend down with the ultrasound, some cysts that don't have bleeding in them. And so, just a very large lesions with certain areas of bleeding. So we decided to do an ultrasound guided aspiration with doxycycline sclerotherapy. We took out about 73 cc's of clear or serosanguinous fluid and gave her doxycycline. It's probably worth mentioning we do audiology testing at baseline because of the cumulative risk of ototoxicity when we anticipate multiple doxycycline sclerotherapy treatments, we would often do that as a baseline. Now, she did present a week later with evidence of thrombocytopenia and bleeding with anemia. So this time we decided to do a more aggressive sclerotherapy, this time with 4 pigtail catheters. And of course, this is a large undertaking, again, with general anesthesia, as you can see, and multiple pigtail catheters being placed. We can inject dye within them and look to see the extent of the cavities, how they fit into the entire mass and how they connect to each other. But you can imagine this is quite an undertaking. It requires an ICU stay. These are painful indwelling catheters. The advantage is that it allows for passive drainage, and so potentially less physiological impact to the infant. And so we did drain after a few days, total 400 cc's of fluid. We gave her more doxycycline, then of course involved more general anesthesia. And you can see here a relatively smaller looking lesion. Unfortunately, a month later, she came back, no bleeding or fever, but continued enlargement of the lesion. Short amount of time later, she came in with a second infection. She did respond to intravenous antibiotics again and did well. But at the third infection a month later, that's when we decided that even though she was only 9 months old, we were going to have to plan for a resection because she simply wasn't going to be able to grow to the 1 or 2 years of age that we had hoped. So at 10 months of age, we did do a resection. A total of 2 liters of fluid came out of the mass and over 600 grams of tissue. And you could see here that very, very large prominent draining vein here is under in that photo. And this is her at the completion, the large extent of her resection, but you can see the dramatic reduction in size afterwards. And she did very, very well. This is here at her post-op, and she celebrated her first birthday. No recurrence at 2 months of age. You can see at that point, the decision was made to resect the secondary lesion at the posterior back. And again, she did very, very well with this. You can see her here with the drains in. Post-operatively, she did very well. So the pathology, which was what was so interesting, is, these 2 lesions were different. We felt that they were different. The first one was consistent with a lymphovenous malformation based on both the cellular appearance and the immunohistochemistry. The second resection was different. It was more of a lipomatous malformation. And given the fact that we could not fully resect this, it was a massive resection, but by definition, the size of the lesion precludes our ability to completely resect a tumor, or a lesion rather, not a tumor. And also because of the retroperitoneal component of the lesion that was unable to be easily resected, we felt that she would be a good candidate for sirolimus therapy. And she was maintained on this for quite some time and did very well. At one point, we did think at age 3, we thought she had some hemihypertrophy potentially and appeared to have a closed phenotype. We tested we went back and tested the initial surgical specimen and did find that she had a mosaic for a PIK3CA mutation. and realized that she would respond well to the V-Joyce therapy, this targeted PIK3CA inhibitor. And she, after several years, 3 years total on that, she has reduced the size of the lymphatic retroperitoneal malformation. As you can see, that's demonstrated here by 90%. So she has done very well without any significant complications from these medical therapies. And she's now 6 years old, doing very well. And I think at this point, I'd like to introduce Dr. Dana LeBlanc to add some commentary. She is our medical director at the Children's Hospital Medical Anomalies Clinic and part of the Hematology Oncology Department at LSU School of Medicine. So I think Dr. LeBlanc, I'm going to mute my screen, and I think maybe if you'd like to make any kind of comments, because you've been involved with this patient as well.
Yeah, sure. So, thanks, Claudia. I have been practicing here at Children's Peds Hemonc for around 9 years, and but just relatively recently became involved formally with the vascular anomalies team. And I think I was, as you were going through this case and remembering this patient, I think that, you know, Hemonc, I think was not, again, was not routinely involved in the vascular anomalies team in the beginning. So when this patient was born, we probably weren't a big part of that team. We were not a big part of that team at all. But I think now, if we had had a similar case, we would have started medical therapy a lot sooner. And so once I met her, she had already had all of her surgical interventions, but she definitely still had residual malformations. And there was certainly some concern that we knew that there was residual, that she was going to have some recurrence or some progression at some point. So sirolimus was kind of our initial therapy. That was prior to the FDA approval of V-Joyce and prior to us having the genetic results back for the PIK3CA mutation. And so sirolimus, I think, Claudia, do we have those other slides if you want to flip forward?
Oh, I'm sorry. Yes.
That's okay. Well, just a little bit about CLOVES. I think we've already kind of gone over CLOVES. So the congenital lipovenous overgrowth, vascular malformations, epidermal nevi, and skeletal abnormalities. And so in this patient, she had the big truncal lipomatous mass that was noted at birth, as well as the lymphovascular malformation of her trunk as well. And then for sure for CLOVES, you have to watch out for like all the other skeletal abnormalities, particularly scoliosis that can also develop. Of course, the multimodal management of these patients is so important to all of our vascular anomalies patients. So options include things like observation, debulking or resection, which this patient had, sclerotherapy, which this patient had. Some patients with arteriovenous malformations benefit from embolization. And of course, medical management and supportive care is also really important for most of these patients. Again, like in the beginning, I don't think that we had really, or the team had really pursued a lot of genetic testing for her because it wasn't really something that had been emphasized. I think a lot of the management was a lot more surgical in nature early on or interventional. But through next-gen sequencing, so many now vascular anomalies are found to be caused by mosaic mutations. And it's in these really kind of highly conserved genes that control cellular proliferation. So as Dr. Bly mentioned, there's like kind of those two main pathways. There's like the RAS, RAF, MEK, ERK pathway, as well as the PIK3CA, AKT, mTOR pathway. And we have drugs that can target it either of those pathways. And in the setting of CLOVES, it's more of, we now know that it's more of PIK3CA mutations that are driving that pathway that you see right there on the right, which is why medicines like sirolimus, which is what we've used as an mTOR inhibitor initially for her, as well as V-Joyce or alpelisib, which is a PIK3CA inhibitor, are effective. So you can go to the next slide. And then again, just kind of what I was saying for this patient, she did well with sirolimus. She was medically stable. There wasn't any progression of her disease on that medication. But after we obtained the genetic testing results that showed the PIK3CA mutation, that's when we made the decision to switch over to alpelisib, which he's also done very well with. And that's the one that we've seen that she's had this further reduction in the size of her malformation, and she's really having 0 complications or side effects. So just, you know, we always kind of, there's sometimes some debates within our team about whether we should be pursuing targeted therapies versus should we be pursuing more medical management. Medical management versus more surgical management. And I always try to, like, we can do medical therapy, but we all have to remember that that these drugs are not always benign, and that there's a lot of monitoring and observations that need to happen. But in summary, our patient has done really well on B-joist, and we're thrilled with her outcomes, and we continue to follow her. And she's what now, like 6 or 7 years old, and doing really great.
Great. Well, I think that we have about 5 minutes left or 4 minutes left for questions. If anybody would like to ask any questions. And if not.
This is Romeo Ignacio from San Diego. First, I want to say hi to Sandy. Sandy used to be my partner in the Navy, and I just wanted to ask her a question about how did you facilitate the flow within your clinic of who sees them first, who sees them last? And I know it seems to be difficult logistically because I can't seem to overcome that obstacle. And then the second one goes to the exact question from that great presentation. How have you overcome or decided genetics up front or not? Is it, you know, do you guys decide case by case, or do you have a set of criteria deciding who gets genetics or not up front? Again, great presentations.
Yeah, thanks, Romeo. Maybe it's great to see you on this talk. Maybe I'll have a Fran kind of address how we manage those.
So yeah, hi Romeo and everyone. Thank you. So we do the virtual conference. I've been in all different settings at different institutions and different combinations of vascular programs, and different places have like a more alpha, it could be more of a surgeon oriented or interventional radiology or medical oriented, depending on the institution where you are. But we find it more efficient to have the virtual conference. So not every single patient that all of us see is presented in conference. We have, last time we had 17 patients that we discussed one evening, but it's usually like 13-ish patients that we meet every 3rd week, but we also meet ad hoc for complicated patients that we can't wait the 3rd week. So the reason why I like the virtual conferences, at least one of us have seen that patient separately. So you get a really good history, a really good exam. You've sent whatever labs you want. You've done the imaging, or you've spoken to the radiologist with suggestions. What should the imaging be? So when you're presenting the patient, everything is there, instead of like, no one really gets a history and no one really does, they just look at their part of the exam. And then you have a laundry list of things that you want to order, but then you have to meet again. So after our conference, usually at least one person will then see that patient sometime. And then we try to organize it so it might be the same day. So they might see ENT and interventional radiology, or, the plastic surgeon or Sandy and someone else. Genetics is a bigger issue. And, we try to get genetics on any patient that's having surgery anyway. We try to have genetics involved as much as we can. Finances are a huge issue with sending out genetic testing and getting the biopsy. When are you going to do the biopsy? Some of them can just be a simple punch biopsy, but some have to be wider resections. So it's very individualized, and we send them either to, if it's a somatic mutation, we send them to Seattle. There's a good lab there run by that group, or Washington University. It's a huge problem. We had to get an override for New York State because they have to be CLIA certified in your own state. So every state will have its own regulations. And then whether they're done inpatient or outpatient is different insurance-wise. It's a mess. It's really, really hard. And then who does the biopsy? So it depends on the case. Sometimes it's dermatologist, sometimes it's surgeon, sometimes it's the geneticist. It really depends. There's no one formula. We do the best we can. We've have pretty good yield with the results. We have actually we have 2 posters at 3 posters at ISFA that are like surprises, that we're you know, different from what we thought. So, and it really helps with management. So that, I don't know if that answers your questions, but if you're
It
struggling,
is.
you're not alone. Every place has their own kind of learning curve and process.
No, those are some good tidbits of advice. I appreciate it.
I guess our 4 minutes are up.
Yeah.
Hey,
Well, I
Don,
think we're going to have
Okay.
some time to keep
Okay.
talking, and I anticipate there are going to be some shared themes across these two distinct panels as we think about just the landscape of care provisions across different centers in the United States. So we really picked a lot of zebras to talk about tonight, and that was such a high-level overview, beautiful case review. I just want to say thanks to all of you for sharing. I am going to insert myself now. I don't see Dr. Morrissey on, and I know he was tackling a pretty complicated case today in the OR. So my co-moderator may join us in a bit, but in the interim, I am going to move into the next segment of the webinar. And this is going to be a little less didactic and more of kind of just a case review, thinking about different ways to treat the same problem when we talk about a really specific set of rare diseases along this developmental spectrum. And so I do want to introduce our next sets of panelists. So if you'll give me just a few minutes here to welcome our speakers. And we have just 3 short slides for people to contemplate. And I'm hopeful that others in the audience can join us and ask some questions, and that this will be, you know, fairly casual. I'll keep each case to about 10 minutes if that's okay, so that we can open it up to larger discussion before we lapse. And then I'll have a few other just slides for comment at the end to acknowledge some really important supporters and stakeholders and hint at what's next for all of us. So let me first welcome from the University of Michigan, Dr. John Eliason, who is the S. Martin Lindenauer Professor of Surgery and the Executive Director of the Michigan Aortic Program, and my former partner and mentor in the practice of caring for children with pediatric vascular disease. We were both strongly mentored by Jim Stanley, who's joined us tonight. I also want to introduce one of the newest faculty recruits to the University of Michigan, Dr. Bobby Beaulieu, who's really taken over as a co-partner to John in the surgical practice of pediatric vascular disease, and they're going to keep that program right on humming. So welcome to the both of you. I'd also like to introduce our team from the Children's Hospital of Philadelphia. Dr. Anne-Marie Cahill is with us today. She is the professor of radiology at the University of Pennsylvania. She's also the division chief of interventional radiology and director of image-based therapy for vascular anomalies at CHOP. And Dr. Alex Fairman is with us tonight, and he's an assistant professor of surgery at UPenn and the new director of pediatric vascular surgery at CHOP, and has a really interesting appointment that I might be a little bit envious of, and he's going to do great things there, surgically speaking. So welcome, Anne-Marie and Alex. Thanks for being here. And we have a couple stakeholders from our Boston Children's team. So I want to welcome Dr. Michael Ferguson, who is, we hope, soon to be an associate professor in pediatrics and a pediatric nephrology at Harvard Medical School. He directs the renovascular hypertension program at Boston Children's and co-directs their Center for Mid-Aortic Syndrome and Renovascular Hypertension. And he is with Dr. Alex Cuenca, who's an assistant professor of surgery, I believe, with a specialty in transplantation. So we've got a really broad set of specialists who represent several different disciplines at what I think we would consider high volume centers for referral. I'm going to share my slides, and I'm just going to moderate a few cases for all of you. I do have a few specific questions for the cases, and I want other people to chime in either through the chat, which I'll continue to try to carefully monitor, or frankly, just kind of interrupt and speak. It'll be so fun, I think. So hopefully you can see my screen. Does that look like a good screen? Not the presenter view?
Yeah, that looks good.
Perfect. All right. So this is our first case. And this is a patient who is 10 years old with 4-drug hypertension that I'll say is one of those medications is an ACE inhibitor. Echocardiogram supports left ventricular hypertrophy. The child has blood pressure measurements that are poorly controlled. They're in the 160 systolic, we'll say, and frequent headaches, but otherwise an unremarkable gestational and medical history, no prior surgeries. And I wanted to start with Dr. Ferguson and just ask a bit, when you're seeing these kids with hypertension and you suspect a renovascular cause, can you comment a bit, maybe briefly, on the expanded workup, specifically when you're thinking about additional imaging? And I'm hopeful also that you can share a little bit about how you prioritize which classes of drug treatment for these children.
Sure. So typically what we start with is, a metabolic panel looking at renal function and electrolyte balance that can help us prioritize where we're going to go with imaging. And I think a renal ultrasound with Doppler studies is almost always the first line. And we typically will start with a calcium channel blocker because they're very safe and you're not going to get into trouble with complications. Looking at this study and seeing that this patient is on an ACE inhibitor, that makes me a little bit concerned, to be honest with you. You've got a significant bilateral renal artery stenosis. If this child were to get dehydrated or have other problems with acute illness, there would be a very high risk of acute kidney injury.
Thanks for that. And obviously, I'm showing you an image that supports bilateral osteal stenosis. And I guess I would just turn this over to the panel. My first question when we think about treatment indications, and maybe I'll ask John Eliason to start. What is your threshold for revascularization when kids have hypertension secondary to a renal artery stenosis?
Thanks, Dawn. I think that this is where the multidisciplinary part of the decision making, I think, is so important, because it's not everyone's so individual, and there can maybe multiple iterations of antihypertension control that get worked through before a decision is made of whether or not there's been refractory hypertension and medical failure. So if we all agree that 3 or 4 drugs or drugs with multiple side effects that are not tolerable have led to a failure of medical management, then surgical correction would be considered. And in this patient, I think more than some others, you would probably have a higher chance at getting a really good outcome with reimplantation of both renals, and maybe even getting the child completely off medicine.
Thanks for that. Michael, let me ask you another question just to follow up what John's shared. And I will say that we've classically been trained, at least as surgeons, to think about hypertension as our key metric that really has determined when we think about revascularization. But are there scenarios in which you might consider surgical intervention simply for renal perfusion, or thinking about long-term sequelae of chronic kidney disease when perhaps the blood pressure isn't as severely altered?
Yeah, so a child like this, we would definitely follow with serial imaging, even if the blood pressure was well controlled, to ensure that the kidneys were growing appropriately. We'd also check echocardiograms periodically to assess for other end organ damage. But I agree with what John said, that I think where we see the highest success rate is with surgical intervention. I think that obviously with this osteal stenosis, one could consider doing an endovascular intervention, and I'm sure Dr. Cahill can talk to that. But yeah, I think that this is somebody who clearly requires a very, very close monitoring for end organ damage.
That's a super segue. Dr. Cahill, when you're seeing these patients with your multidisciplinary team at CHOP, when are you selecting patients for an endovascular approach first over a surgical revascularization?
And I'm glad Alex is on. We now have Alex, so that was a big consideration in the past because I've worked for many years without a dedicated vascular surgeon in our group. Historically, I would say if there isn't a mid-aortic stenosis and there is a possibility of us doing angioplasty and the kid is younger, we're trying that with staged angioplasty.
Yep.
Particularly in the setting of my practice, because I'm using the cutting balloon for resistant renal artery stenosis. So that adds an advantage, because looking at this particular picture, I am pretty sure a regular balloon is not going to make the, give you the result that you need. And it buys time. If it's not syndromic, we have seen, and we'll be publishing our data pretty soon, that it is more successful than NF, which is syndromic. And if they are older, I mean, it's really a discussion with Alex about the likelihood angioplasty will work. The cutting balloon, we've had a couple of pseudoaneurysms at the origin. I've just out of the whole series of 35 cutting balloon angioplasties, I've had 2, but still 2 is more than I'd like. And so, yeah, I mean, it's about local expertise, I think, and that's variable, obviously. And Alex can maybe weigh in a little more now that we have him dedicated to us on a regular basis.
Yeah, thanks for that. I'm also just going to ask Dr. Fairman to share a little bit on conduit considerations when you're thinking now about the practice that's expanding with surgical support at CHOP. Dr. Eliason had proposed reimplantations for these osteolesions. What are your thoughts about this case from a surgical perspective? And when you're thinking about conduit for kids in this intracavitary position, what are you prioritizing for conduit choice?
I like to think that I try to keep everything as native as possible. I definitely agree with Dr. Eliason here that if you can reimplant those, that'd be ideal. Sometimes, you look at the imaging and then you dive in there and the things are a little more under tension than you want them to, and you obviously want to avoid that. And you also want to avoid trying to mobilize the kidney so much that you're disrupting some of the collaterals that have developed over the years that may be important if your bypass, unfortunately goes down to keep that kidney alive. So you want to be careful of that. If you can't reimplant, you think there's a little more tension than you'd like, my preference is to take the hypogastric. In NF1 kids, I have seen that their hypogastric tends to be pretty thickened at times, and you can't really use as long of a segment as you want. You're sort of stuck with trying to reimplant the left or right renal if you can. If they're older and they're done growing and they're done puberty and they're pretty normal size, I don't have a problem using a prosthetic if you don't have a native conduit available. It's nice to have that 5mm ring PTFE graft to use for renal artery bypass if the size matches up. But obviously I'd like to use their own artery if possible.
I'm going to ask Dr. Cuenca to comment on the role for auto transplant in these cases, because again, I think different practice patterns evolve at different centers based on who's available and what skill sets you have to support these really rare diseases. And so, Dr. Cuenca, what are your thoughts about a patient like this? And are any renal reimplantations being done at Boston, or does everybody get an auto transplant? And how do you make that decision?
Yeah, so I think for the most part, we do consider more auto transplant because the both of us that do these cases, or the 3 of us that do these cases, are transplant surgeons, and we feel like we get a better sort of anastomosis and less tension on the anastomosis if we do that. And in a case like this, where it's really just at the ostia, you get a really nice length of renal artery to do that. We have had some instances where we have moved the renal artery or transposed the renal artery or the renal vein to basically keep it in place and not sacrifice those collaterals that are coming through gerotas. But in general, our practice and philosophy is to move the kidneys wherever possible, and we feel like the anastomoses are better when they're to the iliacs as opposed to the aorta, just from the sew perspective. And when we
Just
follow
from the what perspective, I'm sorry?
the technical perspective of sewing it back to the
I
aorta,
see.
tension on the kidney in general. We do find that when we, regardless of what we do, when we do re-implant these arteries onto those vessels, that the kidneys are obviously very sensitive to this sort of, it's almost like a reperfusion injury. And any sort of, we have to support the kidneys and the stretch on the artery, even if we keep them transposed, to make sure that there's not a whole lot of extra stretch on the anastomosis for upwards of half an hour to an hour, to make sure that because what happens is that basically the kidney is seeing a new pressure head of flow and such. So but that being said, usually over time it just normalizes, like over time during the period of the operation.
Let me pause for a minute and just get thoughts from other panelists or from the audience around this particular case. I have a couple more questions, but I don't want to dominate the discussion.
I just want to add that the approach that Alex describes, I think so many more of our patients who have had auto transplants normalize their blood pressure and have preserved kidney function. And obviously, different centers have different approaches. I don't want to say that what we're doing is best. That's not my intention. But I just looking at our history, the auto transplant patients seem to get off blood pressure meds earlier and have preserved kidney function. And so I just wanted to add that.
Somebody tell me about surveillance and medical therapy after a case like this. How often are you imaging these renals with ultrasound? How long are they staying on antiplatelet therapy? What does that look like?
So Alex can talk to, most of them are on aspirin for a period of time. We do pretty frequent ultrasounds to ensure that the kidneys are, happy and growing appropriately. Most of our patients who have had auto transplants or even reimplantations, we are doing, CTAs at some interval, and then we back off on that. But we do frequent ultrasounds to ensure that we're not missing something.
Alex, what do you guys do?
Oh, sorry.
We do the exact same thing. And if I'm worried about a kid or, it was a more challenging case, I surveil more frequently, but it's usually ultrasound with some aspect of the perfusion scan within that ultrasound.
Yep.
Bobby, you get final comments on this case.
Oh man, after all the people who know what they're talking about, I've already talked. No, I mean, I think obviously this is a child that looks like they'd benefit from surgery, and reimplantation as a first line approach makes a lot of sense. And I think you surveil them afterwards in combination with their nephrologist. A lot of these patients will travel to get their surgery done. They may not be local. So I'd say a point worth considering is the discussion you're going to have with their home nephrologist regarding how often you want to be checking labs, or you do want to check their, antihypertensive regimen, because sometimes you'll see these children back a year later and their regimen has crept up and you don't know when that happened or how it happened. And all of a sudden you're trying to play catch up on what may be a bigger stenosis to treat.
Yeah, it's really, you agree, Michael. That's good. Let me ask just one last question because it popped into my mind as I transition to our next case. But one thing our PCORI funded collaborative has taught us as we listen to our families is that 90% of these families travel out of state for care, and they're split. Half of them have to fly. They're traveling so far, and most of them are in the hospital for weeks at a time, which is a significant financial and social burden to these families and patients. And so I'm just curious if anybody has some guidance or best practices or other resources that they're leveraging to support these families in their care and in their travel in that capacity.
So we lean very, we really rely very heavily on our social workers. And fortunately, we have a social worker that's a part of our program. There are often, challenges to getting coverage for people who are out of state. And so that takes some time. So we work with patient financial services to see how we can get them here and not, bankrupt the family. So there's a lot of work that goes on in the background for sure to get the families here and to try and minimize their financial burden when they're in Boston. So it's not trivial at all.
Anybody else have some best practices? I do want to share that there is a resource called Children's Flight of Hope, which is a great charity, and it's really, really perfect for kids that need assistance with travel for their medical care. And so we're leveraging it here at Duke, at least for some of our congenital cardiac and now these renovascular hypertension patients. And that's been a helpful resource. And I know at the University of Michigan, there had been some fundraising from a grateful family that at times has been able to offset some expenses, but that gets a little bit tricky. But it's a really tough spot. And it's just, I think, a gentle reminder to all of us that, that the system right now as it stands isn't easy for all of our patients to access. Well, let me move on to our next case, if that's all right with you guys. This one's going to be real fun. And this is a 12-year-old with 4-drug hypertension who has developed acute kidney injury with an ACE inhibitor, also has LVH on echocardiogram, but really no other substantial symptoms. And again, I'm going to say right now, just to keep things simple, no relevant or known gestational or medical history. And again, you've got a preteen who's essentially asymptomatic with poorly controlled blood pressure. And I'll share a couple images here for you that highlight a few things that are noteworthy. The first being that you've got an osteal stenosis on the right side in this arrow. You've got an irregular narrowing on the left side with this aneurysm. So I do want to call your attention to this aneurysm. If you look at this sagittal view, the aorta is narrowed, significantly so, kind of starting at the level of the renal arteries. And you can see the SMA is occluded here. I'll just propose that the celiac artery has a modest stenosis, but is patent. And then there's poststenotic dilation of the terminal aorta down here. And so this is a case of mid-aortic syndrome. And I want to talk a little bit about this diagnosis. And I don't want to get into necessarily all of the nitty-gritties about some of these, but I'll ask a few targeted questions to this panel, because I know that there are experts on the call that manage this disease really differently. And in comparison to the patient we just talked about with just renal artery disease, now you've got a lot of visceral and aortic disease concurrent. Tell me, Michael, when you see somebody like this in your center, how are you expanding your workup like we just talked about for the last case? When you're thinking of aortic and visceral disease and aneurysm, what else are you thinking about when you're seeing this patient from a differential diagnosis and workup consideration?
I think that the majority of patients who we see like this, it winds up to be idiopathic, but of course you have to think of syndromic causes like Williams syndrome, neurofibromatosis, and Alagille's being some of them. What we typically do is, if we get these images and they're referred to us, we sit down with a large multidisciplinary group and we go through them. And try and figure out what the best next test is going to be, and if intervention is required, what intervention is best for that individual patient. And I think, as the earlier talks mentioned, outside of renovascular hypertension, I think that the key here is having a multidisciplinary approach so that we've got all the people in the same room to sort of look at this and see what we need to do next. And I'm sorry, I can't really see here, but is this is the IMA, is that dilated? I can't.
I'm going to tell you that the IMA is dilated, and you're right, it's hard to see, but it is in fact dilated, and you've got large meandering mesenteric vessels.
Yeah, so, this is, and Alex can talk to this. This is a patient that, if they're on 4 drugs and not doing well, this would be a patient who we would consider doing, the procedure that was developed by Dr. Kim and Dr. Vakili and has been continued with Dr. Cuenca. I'm sure he can describe it better than I can.
Yes, probably. And I want to talk about that. I want to hear from John Eliason how he would approach this aortic disease, and surgically speaking. And then I want Dr. Cuenca to follow. And I'm hopeful that you can expand a little bit on your MAGIC procedure, if you're still using the Tesla procedure, and a little bit about how you might treat this patient. The other thing I want you both to consider as you're describing your surgical approach is how you'd manage the viscerals and the renals with this reconstruction and that aneurysm specifically on the left. John, do you want to start us off?
Sure. Well, nice quality angiogram. And I think the first thing that you can see is, it's always amazing how long children can go with collateral flow before they kind of sometimes reach their limit in perfusion of organs. So just amazing collaterals, which it's a very nice angiogram. But as long as the pressure in the aorta, in the descending thoracic aorta, is kind of normal with the arch, then I would think that the thoracic aorta would be a good donor location for an aortic bypass, and then reimplant the right renal artery. Probably move the left renal artery, the left kidney towards the aorta, and resect the aneurysm and reimplant that as well if there's room. And be hesitant to take the internal iliac if at all possible, just because of the collateral network and supply for the IMA. And then since the celiac's not significantly diseased, then it's likely that if the celiac and IMA are okay, that I wouldn't recommend treating the SMA unless it was a situation where the aorta just looked like it was an easy reimplantation. Otherwise, I would leave it alone and leave the other 2 vessels to supply it. I think the aorta is too small to patch and too irregular to patch, and it wouldn't leave you with good reimplantation sites. So,
I'm so sorry if you said this and I missed it. What are you using for your bypass conduit?
Preferring not to do a bypass if at all possible. I think you could mobilize the kidneys in close enough to reimplant these.
I'm sorry, I meant for your aorta.
Oh, PTFE.
And tell me why that over a woven graft or a Dacron graft.
Well, you just won't get degeneration over time. Occasionally, the really old grafts can calcify, but they can, if they're polyester-based grafts as well, but you won't get degeneration of the weave of the graft. And so I think it's the most durable graft for this particular problem.
And any concerns around long-term sequelae from having a prosthetic graft? Have you seen any cases of graft infection, for example?
I'm glad Dr. Stanley's here. I don't remember any.
Dr. Stanley, any in your experience?
Yeah, no prosthetic graft infections. We've clearly had grafts that were too small when we've operated on a younger child. The child all of a sudden got to be 6 foot tall, and on the way really had significant differences. I'll just make one comment. I'm much more aggressive perhaps than others, but I probably would not reimplant, but I'd do a direct anastomosis to that aorta of the SMA end to end. What we've seen frequently with the thoracoabdominal bypasses is that these real narrowed areas, sooner or later, they have a proliferative intimal process that continues, and they'll thrombose. So, trying to preserve this parallel small channel, in my mind, doesn't make a lot of sense. And we've reimplanted end to end a fair number of SMAs into that smaller aorta. It's frequently a very easy fit. You don't have to do much mobilization. But we've never
Thank
seen
you.
prosthetic failures. On the other hand, prosthesis sooner or later will get infected. I mean, it's not an ideal arterial substitute. It's the best we have.
Well, thanks for that. And it's a good segue. I'm hoping Dr. Cuenca can talk a little bit about this MAGIC procedure and how this is shaping out with more mid to long-term data around the hypertrophy we see progressively in that meandering mesenteric collateralus conduit.
Yeah, I guess my first questions with this angio, assuming this area here is normal and or as appropriate size, and then this would be your distal end.
I'm sorry, I can't see what
I'm
you're
sorry.
pointing at.
But essentially, just beneath where that curl is on the catheter, it would be what the normal caliber of aorta is.
Yes. Let's say there's nothing more narrowed, no pressure gradients above that, that's the caliber of the rest of the native aorta approximately.
So, I mean, honestly, when we look at the scans, you can see nicely that this, arc of Rieland or this meandering mesenteric is dilated nicely. It looks like a fairly long length, and with the ostia of the SMA being closed, everything's likely flowing retrograde. So if we consider this, if it looks like there's a decent length when we get into the abdomen of meandering mesenteric artery graft that we can use as a conduit, and without a significant amount of side branches, and we can get these two ends from the IMA to the SMA back together to reestablish that flow and make sure that we're not compromising it, then we would consider this MMA as a graft. And we would measure from where we thought was normal aorta, which, we just discussed was just below where this curl is, to where it's dilated below, to see whether or not we could get an appropriate length. And we can get upwards of, anywhere between 11 to 15 centimeters sometimes of conduit with just using that graft. At least we have, and fairly, this child is 12 years old, I believe.
12, that's right.
Yeah, and so we've actually been pretty successful with getting a fairly long length segment of graft and using that as an autologous sort of conduit. After we've sort of skeletonized the kidney and gotten everything mobilized, we would consider doing the graft first to just make sure that we've established sort of flow from the top to the bottom. And then likely with these sort of very ostial and proximal stenoses, just simply drop the kidneys to the pelvis and perform autotransplants again on this. And the whole process with the MAGIC graft, the MAGIC vessel, which is essentially using this MMA graft as this autologous bypass, what we've seen in particular, it's more striking in younger children, but that the graft ends up growing to be essentially the same size as the proximal aorta, or close to that, over the course of 3+ to 5 years out.
So let me ask a question to that end, because it is a striking and rapid dilation that happens based on what you've published to date. And when we think about adult patients who've got really robust flow through these mesenteric collaterals, we do see aneurysms. And here's a patient with an aneurysm, and let's say this patient has some underlying genetic syndrome like NF1. Do you worry at all about that future conduit degenerating and becoming an aortic, some type of kind of aortic aneurysmal equivalent when the kids are older? And how do you think that will continue to remodel over years?
No, obviously that is a concern. It hasn't been something that we've seen in the some of the longer term outcomes. We haven't seen like any section of the conduit become more aneurysmal or larger than others in the classic sense of what you would think. And essentially, when we look at the diameters of these grafts at proximal, mid, and distal portions, they're all approximately the same. which is a nice sort of segue, and will be a follow-up published, hopefully submitted manuscript in the next couple of months, looking at our longer-term data specifically related to that. But yeah, no, I mean, I think, obviously it's a concern, but not one that we've seen even, I'm trying to remember how many of the NF and Williams patients we have in our cohort, but it hasn't been something that we've seen traditionally.
I'm going to ask one last question about this case, just given the hour, and I'll open it up for additional questions or comments. And then I have a couple of closing slides to share. But Anne-Marie and Alex, let me just ask at CHOP, how would you guys approach this, just in brief? And then two, do you think there are any advancing endovascular techniques that you would consider either in a 12-year-old, or let's say this child was 18 months?
Alex, do you want to go ahead?
Sure. I would take a similar approach to Dr. Eliason. That left renal artery, I would just have to see when I was in there if I could reimplant that or not. That may need a bypass. But otherwise, I would take a similar approach to Dr. Eliason. I tend not to be very aggressive with reimplanting or revascularizing the SMA or celiac if the kid has no symptoms whatsoever. That's just my philosophy. If anything goes wrong when you're trying to do that and they've never had symptoms, I would feel, a little bad about that. But I think in terms of your question about new endovascular techniques, I think an even more important question is, what is the role of endovascular, therapy in salvaging some of these things over time, particularly these really complex patients like this. And I think, there certainly is a role. We've had to salvage some of ours through endovascular techniques, whether it's a thrombectomy or it's stenting or ballooning. And I think that's the more important question. And the ability to have both of those tools at your disposal at your center is really key for these kids, because no matter how perfect the repair you do, these are really complex patients and do need secondary interventions.
I would just like to make hopefully a constructive analysis of the angio. In our center, we would not go from below. I wouldn't like to be trying to navigate a wire through a dilated aorta and up a narrowing without actually anticoagulation at least on board, having a catheter there. We would have gone from the left axillary artery down and performed an angio. And I would think, Alex, in this kind of case, we may have tried endovascular on the right kidney. If you wanted to see how one does before you violate two with surgery potentially and have a problem, I'm not sure. But we have used angioplasty in the cutting balloon to buy time in these kind of patients. So unless you want to do both kidneys at the same time or not, I know that you probably do because the surgery is extensive. But yeah, the left axillary artery in our world is a safe artery. It's been published down to 2.5 kilos for access. It performs like the femoral over the femoral head. You have the humeral head. And rather than traversing these tight stenosis, we would do an axillary. Yeah, just out of interest. Yeah.
Thanks for that comment. Let me just ask if there are additional thoughts or comments from the panelists or the audience.
Yeah,
I treated this. Oh, who's that?
Hey, it's David Rusting. Thanks to everybody for the presentations. I'll follow up on the question you had in the previous panel. Like, what do people do for anticoagulation, especially in kids, and what are the follow-ups? And do we have long-term registries? We're super interested in this joint task force. How do we transition from pediatric to adult care and practice and extend that long-term follow-up?
I will propose that for a patient like this, and I'll tell you what I did for this child who did get a PTFE aorta to aortic bypass, as Dr. Eliason and Dr. Fairman referenced. This patient ended up, though, having a little of a different approach to the renals and the SMA specifically, in that I syndactylized the right kidney and the SMA together, reimplanted those directly onto the terminal aorta, just below that proximal anastomosis. And then I cut back the renal aneurysm and directly reimplanted that end to end onto the terminal aorta just above the IMA. And so I did reconstruct all of those vessels. A kid like that with a prosthetic graft is going to stay on aspirin for 2 years at a minimum when there's a long kind of PTFE aortic graft. And we used to stop it at 2 years. And I'll say I've had a couple kids come back with some mural thrombus, and I've not yet seen one case of Reye's syndrome. And so frankly, I've started extending antiplatelet therapy kind of indefinitely at this point. If there's no prosthetic and it's a simple reimplantation, I've chosen to stop the antiplatelet therapy at 6 months. I will also comment on the registry concept, and it'll be really a nice segue into the closing slides, just to direct people's attention to our PCORI-funded collaborative. We've got a group of multi-center international centers of excellence and patient family stakeholders that are supporting some intentional collaborative work. And there's some exciting work on the very near horizon with the goal for cohort creation, so we can better phenotype to understand both natural history and some comparative effectiveness research for some of these kids. And so I do think that that's coming and is a really exciting thing. And I'll share a little bit of information on some of our closing slides to that end. And most of the people, all of the people who are participating in this panel have an affiliation in some capacity with that collaborative. Other thoughts to Dr. Rothstein's question around antiplatelet therapy, anticoagulation, other known concepts or considerations around registries. That is an important topic, and I'm really glad you raised that. Okay, it was a super, super ambitious agenda for tonight, but I'm really, really thrilled and so grateful for everybody that chose to join us this evening. I did want to just share a save the date for our next interest group, which will have a hybrid format for those that are going to be with us at our vascular annual meeting in Chicago. We're going to dig back into pediatric vascular trauma. It'll be a lunchtime session again in Chicago time, and we'll have a Zoom link for our APSA partners to join us if they're available. I wanted to, again, kind of highlight our collaborative, share the link so that you can share with your patients and families if you're approaching this disease process. There are a lot of resources there. I want to credit our whole collaborative and just suggest that we'll have a symposium in October to dig into this a little bit more. So please save that date and join us in Durham. And I guess kind of last but not least, I just want to acknowledge again our SVS APSA collaborative. This task force has the potential to be very powerful, only made as powerful by our membership, which are all listed here from our respective organizations. And I just need to thank sincerely our SVS leadership, inclusive of the strategic board, Dr. Slaw, Riva Bouchan, and Mary Bodach for supporting us and this vision. We're working now on a shared supplement that will be co-published between our JPS and JBS, and we've got the final green light within the last 7 to 10 days to move that forward. And we're really excited about what type of resource this will be from an educational perspective to our respective members. So more to come there. We hope to see everybody again in June. And we'll be reaching out to everybody that participated tonight and that's on the listserv with guidance on how to access the recording in the future. And then also looking for ideas for content for upcoming webinars. So thanks again, everybody, for sharing your time with us and your interest in these patients. And I can't thank all of our expert panelists enough for sharing all of their knowledge and enthusiasm for these rare diseases. Have a great night, everybody.